Thank you, Manu. So it's so important, many of the times I think we start learning, those days when we were trained, we did a very few cases of ICCE followed by suturing and practicing under ECCE, then small incision, and then we came on to learn Phaco. But now I think we train our young residents to do a good and a high quality small incision, and the transition to Phaco is much more simpler, and also the results are really very optimal and appreciable sometimes. So I'll just share with you how we do that. And when you're doing your last few small incision, it's good to start temporal small incision, because you are so comfortable doing with a bridal suture and the superior small scleral tunnel. But when you're going to start Phaco, I think you'll be sitting temporally and doing limbal or clear corneal. So it will be nice to start doing a few temporal small incision, and also practice making the left-handed side port. Normally in an SICS, wherever you want, you can make a side port either for cortex aspiration or reforming the chamber. But here it will be good to make a left-hand side port so that you can practice all your second instrument, and try to master the technique of rhexis through a smaller incision. When it is going to be a Phaco incision, it's going to be half the size. So some people who have big incisions are comfortable in doing a big rhexis and small incision. So here you have to control the size of the rhexis and also master it either doing through the tunnel or through the side port. And also learn to rotate the nucleus. Before you prolapse the nucleus, just rotate the nucleus when you are doing a few small incisions. Just get a feel of the rotation, so that will be also a good practice to do. And also, if you want to, you can practice bimanual. If you have your machine behind you and you're doing small incision, practice bimanual cortex aspiration, which will be handy when you do. So this is how we orient our trainees to do. Some kind of orientation happens, and then a very critical wet lab practice happen in the first week, followed by assisting a patient on a live surgery. And finally, we review their progress and see how did they do and where they need real hand holding, or if they are ready to go on and do on their own. So this program, again supported by several companies, and Alcan supports. We have no commercial interest on the Phaco development program at Arvind. So this basic orientation starts with understanding the basics. So there is a PDP manager and a surgeon involved as a team to train 1 or 2 trainees for a couple of weeks. So there is an intensive training. The whole day they are involved only in the training process. It starts from reading a particular set of literature in the form of basics of Phaco and dynamics, where you try to understand all the dynamics. We'll not go into detail of that, about the handpiece, about the foot pedal, about the different physics behind it in power, vacuum, and flow rates. And then in wet lab training, there is cumulatively they need to practice 10 hours on foot pedal, and then they practice constructing the wound and side port in both cadaver human eyes and also in goat's eyes, and then practicing capsulorhexis on few innovative devices. And then we have a way of doing sculpting, cracking, which I'll show you later. And then once they get into the operating room, the second week, they will do 2 cases a day under supervision by a senior Phaco surgeon, and also the PDP manager will be closely watching the different steps, recording the case, seeing how they press the foot pedal, and see how the second instrument handling of the Phaco dynamics, and all that will be critically reviewed, points of it which will be noted. And finally, the trainee, the senior surgeon, and also the chief medical officer sit with them and review their cases and see from there on how they go. So there are a lot of ways you can simulate a surgery. There are expensive simulators, but many of the times expensive simulators really don't give you the feel which you want to get. So we have simulated different ways, which is quite popular. We have published this also sometime back in IJO. So basically here we use a goat's eye. You make a goat's eye, and then you fit it into a chamber which will hold it, usually a camera box, which you don't get now these days. So what we have devised is, we have devised a new innovative idea of a vacuum holder. So there is a holder which is sized for an eyeball, and then with a mechanism of putting a syringe behind it and using a vacuum, it holds the eyeball now very nicely. And you make an incision through the cornea or through the limbus, and then you remove the anterior capsule. This anterior capsule is like a pediatric cataract. No, if you want to learn pediatric rexes, you can learn here. It's not, you don't get a feel of adult. It's very difficult. You need to control with a capsulorhexis or an Utratas forceps. And after that, you remove a little bit of the lens matter, which is really soft there, using your Phaco probe. You remove a little bit of lens matter, and then you give sufficient space inside the capsular bag to put a harvested human nucleus inside. We have seen some brilliant ideas of doing that in other ways, where you have shells which are available. Some of the trade which is right opposite, I saw it's available, but there is no feel like doing it on a goat's eye with a human nucleus inside. No, we have tried all this. So this is really it's a fun to make, and also it's a fun to practice in this. So whatever density of cataract you want, you can put it inside. So ideally you should have harder cataracts here, at least NS3, NS4, which is going inside, so that you can practice the Phaco. If it's going to be very soft, again, no, it may become really soft, and this has to be stored in glycerin. And there are ways you can harden the nucleus. You can microwave it. No, you can inject some things inside to make it hard. But basically, if you collect harder nucleus, it will be nice. And you close this incision, and through any other incision, no, 180 degree parallelly, you can make corneal limbal or corneal incisions wherein your probe will snugly fit, and then you can practice. So this practice not only helps you to begin surgery, but also in between. No, for example, if you want to transform yourself from a divide and conquer to a Phaco chop surgeon, you can go back always to the wet lab and practice Phaco chop on some of these nucleuses. You take harder ones, you try to chop the nucleus inside, or you try to do double trench, or you try to do kind of separation of the posterior plate. All that you can practice here very comfortably and safely. And even if you disturb the vitreous like what Minu did, there is no issue. You can even push it back and learn. I saw yesterday a brilliant idea of learning pars plana vitrectomy in the same model. Now you push the nucleus back, and then you learn how to do pars plana nucleus removal with your silicone oil, or with your perfluorocarbon liquids, or using a fragmatome, or using a basket. All that you can practice in some of these wet lab sessions before you do on your own patients. So this is how I think you should begin with. In a wet lab, you practice, and when you're going into the live surgery, these are things which I would like you to keep in mind, because case selection is very important. You have to select your own case. Don't expect somebody else, your nurse or the surgeon or somebody else, because they would select a case which you may not be comfortable. So try to avoid deep set eyes. Try to avoid, these are, because being a glaucoma specialist, I know, never take a shallow chamber. Never take it for a granted. In between, the eye will become really hard and become a big mess. And don't take corneas which are hazy, which are dry for a lot of time, long time. And the pupil, again, is very important. Make sure your pupil dilates. And then all the other issues, normally we don't select, but sometimes you'll land up in the table. Even if you have some case like that landing on your table, better forego that case. Forego the training on that day. Make sure somebody does it comfortably. So try to avoid cases like this. And ideally, I think these are the cases which you should select. So it should neither be soft nor be hard. Ideally, it should cross beyond NS2, I would say, or a nice cortical cataract, something which is white in the center and periphery is somewhat transparent. So where you can do a nice trenching when you want to practice a 4-quadrant to begin with. So some of these cases like NS3 or cortical with PSCC are ideal cases. I won't go into detail because other speakers, but what we ask them to do is to do a temporal sclerocorneal tunnel, and then they go on to do a temporal clear corneal tunnel, and finally, from a rigid lens to a foldable lens in the last few cases of their training. This is how we take them along. And we follow a very meticulous rubrics like this, which is, I'll show you at the end of the presentation, it's in the document. So the scoring starts from a novice, where he gets a score of 1 to 2 to a competent. So every step you score like this. So this is done by the PDP manager, who is cleanly observing how he is doing a rexis, the shape of the rexis, the circularity, whether it is continuous, whether he finishes, and how long does he take. Depending on that, every step he gets a score. And this score can be compiled, and you can track the progress like this. What happened, how was the score for incision, and why did he not do well in the 10th case or the 12th case can be critically reviewed every day. At the end of the day, you can see his surgeries and say, why did he get this score? What could have been done better? So in the rexis, in sculpting, cracking. So every step you score, and finally you get a progress chart. No, at the end of the progress chart, no, if you are consistently above 4, that means you are doing a good job, and you can go ahead and do individually, or else you may need assistance. So in summary, I think a good wet lab practice, like what I said, something which simulates a real life situation, understand the dynamics, ideal case selection, master some of these techniques when you're doing your last few small incisions before you transform yourself to a Phaco surgeon, and start Phaco, wherever, because you want to convert it. If you'll be happy to convert if you have a sclerocorneal tunnel than you having a limbal tunnel. It's very difficult to convert. So start sclerocorneal tunnel, and once you master, then you go to limbal and clear corneal tunnel, and try to do simple cases. And once you master simple cases, you can do difficult cases.